Hi, this is Dr. George Rutherford again. I'm going to speak now about cascades and what is a cascade. Um, the outline here is we'll talk a little bit about cascade analysis, talk about data sources, strengths and limitations, some of the data quality challenges, how we use cascades to look at 90-90-90 and 95-95-95, and some of the core metrics of a fast track city cascade. So the care cascade is a way to show in visual form the proportion of individuals who are living with HIV and AIDS, living, not dead, but living, who are engaged at each stage of HIV care, right? And we use it to identify issues and opportunities to improve the delivery of services, right? And this also has been referred to as the continuum of care. There's been a lot of work on prevention cascades, but that's a topic for another day. So our objectives are to quantify the magnitude of the losses and gaps along the continuum, to identify where along the steps of the continuum programs fail to engage and retain people living with HIV and various services, to identify and analyze causes for the losses and gaps, and to provide information for planning and deciding targeted interventions and improving the existing monitoring and evaluation system. There are two ways to do this. One is to do it cross-sectionally, which is where we'll just look at a single point in time, say December 31st, how many people are diagnosed, how many are in care, how many are on therapy, how many are suppressed on that day. A cohort cascade is different. It takes a group of people, say everybody diagnosed in January of 2020, and follows them over time, measuring attrition along the various steps in the cascade. Because this is tied from visit to visit to visit to visit, we need unique identifiers for this. So let's talk about cross-sectional cascades. Here are the data requirements. We have the number of people living with HIV. That's a numerator. And we get that typically from mathematical modeling, although occasionally we can use vital registration data. This is mostly modeled. Okay. Spectrum is the most common model. The next element is the number and proportion of people who've been diagnosed with HIV and who are alive, right? And then there's this other consideration about who've received their results, who actually know they're infected, as opposed to people who've been picked up in mass screening programs and may or may not know that they've been infected, right? So the numerator is the number of people living with HIV who've been diagnosed and who have received their results. And the denominator is the number of people living with HIV. The same one is up in here. We get these data from HIV case reporting, from estimated numbers of people living with HIV through modeling. That's the denominator, and population-based surveys. Okay, these are like the population-based HIV impact assessments, the FIAs, or the demographic health surveys. Some additional requirements, if we're looking at the number who are receiving care, right? The number who've received care in the past 12 months, right? So 12 months this is a known kind of cutoff, divided by the number of people living with HIV. The sources for this are program records, right? For instance, an ART registry. And then the number and percentage of people living with HIV who are receiving ART. We can get that from program records like an ART register as well. And then finally, the number and percentage who are virologically suppressed. Now, this is defined as less than 1,000 copies per mil. And I think that's a useful one to walk around with. You'll see other places that define it much more strictly, like under 50 copies per mil or under 200. But I think 1,000 is probably about the right number for the purposes of doing this internationally and being able to compare across countries. So it's the number of people living with HIV and on ART who have a viral load of less than 1,000 copies per mil, right? And we get this typically from program records like ART registers or chart reviews or things like that. Okay. All right, so what other data sources exist besides modeling and HIV reporting? Well, we have early warning indicators. This could look at, for instance, retention at 12 months or viral suppression. the FIA surveys, which are these large nationally representative household-based surveys that actually measure this stuff directly in an overall population. The the demographic and health surveys, very similar, right? Where there's a national level HIV testing. The multiple indicator cluster surveys, which generate data on key indicators in the well-being of children and women, and help shape policies for the improvement of their lives, right? And then the integrated biobehavioral surveys, which can be used in any population, but have been heavily used in key populations. All right, so here we go. Here's an example of a cross-sectional cascade done in the city of Kiev. So the estimated total number of people living with HIV is 19,837. The number that have been diagnosed is 14,423, which represents 73% of this number of the 19,000 here, right? Well, the people living with HIV who are receiving ART, that's 10,000 people, 10,462, which is 73% of this number here. And then finally, of those who are receiving ART, what proportion have viral loads less than 1,000? Well, it's 96%. And you can see it's a very high number, so it's 10,028. Okay. So at each step, this gap below what you're trying to get to, right? And I realize this is 96%, but if we looked at it as a proportion of this initial bar, it's it's less than 90%. Okay. So we occasionally use this is what we're using here as a so-called denominator cascade, where a single denominator, this one here, is used across all the data. The other thing we've done here with these numbers is a denominator numerator cascade, where the denominator for this figure is here, the denominator for this figure is here, and the denominator for this final figure is here. So it's 10,000, for instance, here it'd be 10,028 over 10,462 in a denominator numerator scheme. If we did a denominator scheme, it would be 10,028 over 19,837, right? And that's why you would get this lower value here. Okay, so there are the cascade's great for pointing out gaps. So just to go back here one, you can see this big gap here, right? So it's the difference between people who actually know they're infected and people who are in care, right? That's a big gap. Why are there gaps? Is there these problems with access and uptake? Are there structural barriers? Are there data quality issues? Are the data just wrong? And who's most affected by the gaps? That could be geographical, it could be by gender, it could be by age, it could be by occupation, it could be by a number of other things, by key population status. And then how do we best address? So we have problems like low service coverage for KPs, outdated HIV policies or lack of specific policies, a limited clientele, and then always throughout all these things, data quality runs. Okay, so data elements that are not in the cascade, but we need to know regarding the process of care is how well people are retained in care, what the time to initiation of ART is. That is, these are just looking at proportions cross-sectionally, but you could look, as you looked at a cohort, you could not only say this patient went from here to here, but how long it took in that progression. We could also look at the coverage, for instance, of viral load testing and subpopulation groups. So the data quality challenges in the cascade are, first of all, is that the first number, the number of people living with HIV, is based on modeling, right? And that can be especially problematic in smaller geographic areas such as cities, right? Secondly, you're totally dependent on data entry for this to say, who's on therapy, who's suppressed, right? So we have the issue of data entry errors and basically limitations around the quality of data. Now, if we think about the quality of data, there's 6 dimensions of data quality, which are validity, reliability, completeness. That's a big thing, right? Are the data complete? Precision, timeliness, and integrity. And it's important to state assumptions and methods so that the validity of the data can be really understood by whoever a reader is or a user is of these data. Okay, so here's London. So here we have London. Good job, good job. London surpasses 90, 90, 90. This is the 90, 90, 90 here at the green bar. Okay, so they're well in excess of that. Okay. What we don't know is what's the progress towards 0 new infections, the progress towards 0 AIDS-related deaths and 0 stigma. So while it's great for looking at ART coverage and successive ART coverage, it's not great at looking at these other things. So timely diagnosis remains a problem, with 37% of people being diagnosed late, which is, we can look at their CD4 counts at diagnosis, for instance, and if they're very low, we know they were diagnosed late in the course of disease. We have no information on discrimination against people on the basis of sexual orientation, gender, incarceration, drug use, ethnicity, or HIV status. We have no idea of the extent of community participation in epidemic control, and we have no idea of the status of prevention activities. So let me give you some examples here. So here we are in Paris, and this is looking at the people in care by treatment centers, right? Here we are in Kampala, in Uganda, looking at Kampala and sort of surrounding regions, looking at the same thing, the FTCI dashboard. And here we're looking at the proportion diagnosed, proportion diagnosed and on ART, and on ART and suppressed. So it's only 59% of people who have been diagnosed. Almost all of them are in therapy, and a high proportion are suppressed. Here we are in Bangkok, looking at the exact same thing, 91% diagnosed, 70% on therapy. So there's a big drop off there, and 76% suppressed. Okay. So some recommendations. First of all, base Cascade on real data to the greatest extent possible, and build systems to collect and use available tools, right? I'm a big believer in cross-sectional data. There are other people who are big believers in longitudinal data. I think both are useful and have various specific uses, but I would start with cross-sectional and then graduate to longitudinal. Another recommendation is to standardize definitions of the metrics and use WHO definitions, like, for instance, for viral load suppression whenever possible. And for God's sakes, use the data for monitoring specific target populations over time, key populations, race, ethnicity, gender, geographic sub areas. Look at, and if you're working in cities, look at neighborhoods. It's surprisingly revealing. Right? And also to look at the impact of programs and interventions, and using Cascade data at the facility level really isn't cross-sectional. It's much more likely to be cohort. That requires quite a bit more, not quite a bit, but somewhat more sophistication. But I think it's really helpful for facilities to understand how they're doing as well. So the treatment Cascade provides a framework for assessing and improving programmatic implementation and management so that outcomes at each step can be maximized. The treatment Cascade can be targeted based on context, setting, needs, data sources, and understanding of population trajectories, which are critical for maximizing ART benefits. So with that, I'm going to stop and thank you very much. It's a pleasure.